This video will discuss the orbit and its contents. The orbit is the bony cone-shaped area of the skull that houses the eyes, the extraocular eye muscles, a number of neurovascular structures, the lacrimal gland, the lacrimal apparatus, and periorbital fat. The orbit is bounded by 7 different bones, the largest of which is the frontal bone, indicated here in red, which forms the roof of the orbit. The orbital floor is made up mostly of the maxilla, indicated here in purple, and the zygomatic bone, indicated in orange, with a small contribution from the perpendicular plate of the palatine bone, located here at the back of the orbit. Running under the floor of the orbit is the infraorbital groove and canal, which accommodate the infraorbital nerve and vessels. The lateral wall of the orbit is formed by the joining of the frontal and zygomatic bones, which unite with the greater wing of the sphenoid bone posteriorly, shown here in yellow. Along the medial wall of the orbit, in addition to the maxilla and the frontal bones, is the lacrimal bone, which forms part of the lacrimal groove or fossa. This lacrimal groove and fossa lead to an opening called the nasolacrimal canal. The lacrimal groove houses the lacrimal sac, while the nasolacrimal canal transmits the nasolacrimal duct to the nasal cavity. And lastly, the ethmoid bone forms the posterior aspect of the medial wall of the orbit. Here's the ethmoid bone. Just deep to the ethmoid bone are the ethmoid air cells, which are part of a collection of pneumatic sinuses that surround the orbit. The paranasal sinuses are air-filled cavities that in general have 4 functions. First, these air sinuses lighten the weight of the skull. Also recognize these sinuses are lined by nasal mucosa, meaning that they help us to filter and humidify the air that we breathe. Each of these paranasal sinuses opens into the nasal cavity. Some also suggest that paranasal sinuses act as crumple zones in order to protect vital structures, such as the brain, for example. And lastly, the paranasal sinuses serve as a resonating chamber for sound production. Allow me to illustrate through an example. Think for a moment about how an acoustic guitar is constructed. There are a number of strings, 5 specifically, that arch over top of an opening which enters into an empty box. When those strings are plucked, the sound waves enter into the box, they bounce around the box and resonate, and when they leave the box, they leave amplified, and sounding fuller than when they first went in. This same concept of sound resonation also applies to the paranasal sinuses. Imagine what happens when you have a cold. Your sinuses become filled with mucus, and you have a very nasally sound to your voice. This dampened sound results because the sound can no longer resonate throughout the chambers of these paranasal sinuses. And as such, you sound very stuffy and congested. This image on the screen shows a coronal section of the skull through the orbit. Here at the superior margin of the orbit is where the frontal sinus resides. This sinus is contained within the frontal bone. And deep to the medial wall of the orbit, there are a collection of ethmoidal air cells, shown here, which make up the ethmoid sinuses. The maxillary sinus is the largest of the paranasal sinuses, and it is situated under the floor of the orbit. The 4th paranasal sinus is referred to as the sphenoid sinus. However, it is not visible from this plane of section. And lastly, recognize how thin this bone is between the orbit and the maxillary sinus. The maxillary bone in this area is rather delicate. If enough force is applied to the anterior orbit by a blunt object, like a fist or a baseball, it can cause a fracture to the very thin maxillary bone along the floor of the orbit. This fracture is referred to as an orbital blowout fracture, as seen here. Not only would you expect the patient to have a black eye with periorbital swelling, but if the infraorbital nerve is compromised, the patient might also experience sensory loss to the upper cheek and gums. Recall that the infraorbital canal conveying the infraorbital nerve and artery lives right underneath this very thin maxillary bone on the floor of the orbit. If the eyeball is displaced from this condition, the patient could experience double vision. And as we'll learn in a moment, there is a muscle along the undersurface of the eye called the inferior rectus muscle, as shown here. In this type of fracture, the inferior rectus muscle can become entrapped by the fractured bone, preventing the patient from being able to look upward in the affected eye. This too can cause diplopia upon upward gaze. Diplopia is double vision. Here in this CT scan, notice the very thin-walled maxillary bone forming the floor of the orbit on the right of the patient, and here on the left of the patient, that bone has been fractured, allowing contents of the orbit to drop inferiorly into the maxillary sinus. Because of the rich neurovascular supply of the orbit, there are a number of openings in this region. The two largest passageways are the superior and inferior orbital fissures. The superior orbital fissure, shown here, communicates with the middle cranial fossa. The inferior orbital fissure, on the other hand, this crack shown here, will communicate with the pterygopalatine fossa and the infratemporal fossa. And here's another brief word of caution. Don't confuse the superior orbital fissure with the supraorbital foramen here in the upper part of the orbit. Likewise, don't confuse the inferior orbital fissure with the infraorbital foramen located here. The very small ethmoidal foramina shown here along the medial wall of the orbit are for the passageway of the ethmoidal nerves and vessels in order to supply the ethmoidal air cells. And here again is the lacrimal fossa or groove, which houses the lacrimal sac. The lacrimal sac leads to the nasolacrimal duct, which is conveyed through the bony nasolacrimal canal on its course to the nasal cavity. The superior orbital fissure conveys the motor nerves that innervate the extraocular eye muscles. Those nerves include the oculomotor nerve, cranial nerve number 3, the abducens nerve, cranial nerve number 6, and the trochlear nerve, cranial nerve number 4. The superior orbital fissure also conveys the superior ophthalmic vein, as shown here. This vein has no valves, and it is a route of communication between the veins of the face and the cavernous sinus. In addition to conveying motor nerves, the superior orbital fissure also conveys the sensory nerves of the orbit, which are all branches of V1, the ophthalmic nerve. The three sensory branches of the ophthalmic nerve can be remembered as the NFL. The N represents the nasociliary nerve, the F stands for the frontal nerve, and the L represents the lacrimal nerve. Now let's look at the contents of the inferior orbital fissure. The inferior ophthalmic vein, shown here, communicates with either the pterygoid venous plexus within the infratemporal fossa, or it can also communicate with the cavernous sinus. Just below the inferior ophthalmic vein, we find the infraorbital nerve and artery coursing in the groove and canal, on their course to exit via the infraorbital foramen onto the face over the maxilla. The inferior orbital fissure also contains the small zygomatic nerve. At the back of the orbit, there is a common tendinous ring, which is positioned just anterior to both the optic canal and a portion of the superior orbital fissure. This fibrous ring is the common point of attachment for the four rectus muscles of the eye. The four rectus muscles of the eye include the superior rectus, medial rectus, inferior rectus, and lateral rectus muscle. Passing through this common tendinous ring are the two cranial nerves that innervate these four rectus muscles, which include the cranial nerve number 3, which is the oculomotor nerve, and cranial nerve number 6, the abducent nerve. The contents of the optic canal, which includes the optic nerve and the ophthalmic artery, also pass through the common tendinous ring. All other neurovascular structures pass outside of this ring. In total, there are 6 extraocular eye muscles that work in concert to perform the movements of the eye in the 6 cardinal fields of gaze. Also visible in this image is the levator palpebrae superioris muscle, abbreviated LPS, which is responsible for raising the upper eyelid. This muscle, like several of the extraocular eye muscles, is innervated by the oculomotor nerve, cranial nerve number 3. The oculomotor nerve also innervates the superior rectus muscle, shown here just beneath the levator palpebrae superioris. It innervates the medial rectus muscle on the medial side of the orbit, shown here. And it innervates the inferior rectus muscle, as well as the inferior oblique muscle, abbreviated IO. Unlike the superior, medial, and inferior rectus muscles, which originate from the common tendinous ring, the inferior oblique muscle extends from the lacrimal groove to insert onto the sclera of the eye, just lateral to the insertion of the inferior rectus muscle. Cranial nerve number 4, the trochlear nerve, is responsible for innervating the superior oblique muscle. The superior oblique muscle originates from the body of the sphenoid bone, and it passes through a pulley called the trochlea, which is suspended from the medial roof of the orbit. Here's the trochlea, shown here. The superior oblique muscle is very active during reading, as it pulls the eyes both downward and inward. And lastly, the lateral rectus muscle, shown here, is innervated by the abducens nerve, cranial nerve number 6. To fully understand the normal function of each muscle, and to appreciate how cranial nerves are clinically tested, you must first realize that when the eye is in forward gaze, when the pupils are centered within the palpebral fissure, the long axis of the eyeball, represented by the pink dotted line, does not align with the axis of the orbit, which is represented by the green dotted line. In order to keep the eyeball in forward gaze, means that every muscle of the eye must exert at least some tension on the eyeball. The illustration in the bottom right of the screen explains the function of the muscles for keeping the eye in forward gaze. If I went in and cut all of the muscles around the eyeball except for the superior oblique muscle, this muscle would put the eye in both a depressed and abducted state. Again, this is its function during tonic contraction. Don't confuse the function in tonic contraction for forward gaze with the clinical testing of these muscles. This concept of the eye axis versus the orbital axis is very important clinically, and it explains why the H pattern for testing extraocular eye movements is necessary to isolate individual eye muscles. Let's take the superior rectus muscle as our example. In order to test the superior rectus muscle, the eye must first be abducted so that the axis of the eye comes into alignment with the axis of the muscle, which is shown here in green. In other words, we want the pink axis, the orbital axis, to come into alignment with this green axis indicated by the muscle. By aligning these axes, the primary function of the muscle is optimized. So in this instance, once the eye is fully abducted, you then ask the patient to look upward in order to test the function of the superior rectus muscle. If the patient can accomplish this task, then the primary function of the superior rectus muscle, which is to elevate the eyeball, is intact. If you simply ask the patient to look up without abducting the eye first, both the superior rectus and the inferior oblique muscles would both be contracting. This is because the inferior oblique and superior rectus muscles work synergistically during elevation of the eye. Likewise, the superior oblique muscle, along with the inferior rectus muscle, work synergistically during depression of the eyes for downward gaze. So the key take-home message here is that you must first isolate each muscle in order to test its primary function clinically. Here is how each muscle of the eye is tested clinically, and for the purposes of walking through this, let's only look at the patient's right eye. Testing the patient's medial and lateral rectus muscles is very straightforward. To test the medial rectus muscle, you'll have the patient track your finger medially towards the bridge of the patient's nose. And conversely, to test the lateral rectus muscle, you will have the patient track your finger outward toward the patient's ear. To test the superior rectus muscle, the patient will track your finger outward and then upward. And with the eye still abducted, you'll ask the patient to track your finger inferiorly to test the inferior rectus muscle. To test the inferior oblique muscle, the patient will track your finger medially and then will move their eye upward. And with the eye still adducted, you will ask the patient to track your finger inferiorly to test the superior oblique muscle. And this is how you get the H pattern for clinical eye testing. In order to test convergence of the eyes, which is an action used for reading, you'll ask the patient to track your finger toward the tip of their nose, and their eyes will converge as such. For reading in particular, because the eyes are already in an adducted state, both the superior oblique and the inferior oblique muscles will be primarily responsible for elevating and depressing the eyes as you move up and down the page that you're reading. And lastly, I'll point out that for upward gaze, recognize that both the superior rectus and inferior oblique muscles are functioning. Likewise, for downward gaze, both the inferior rectus and the superior oblique muscle are pulling the eyes into depression. Anytime there is misalignment of the two eyes, this is referred to as strabismus, and strabismus typically causes double vision, which is called diplopia. Do take the time to become familiar with how to test the extraocular eye muscles. When we get to nerve lesions, being able to test the function of each eye muscle will help to determine where the lesion is located. Let's take a break from the nerves and muscles of the eye for a moment to look at the arteries of the orbit. The source of blood supply to the orbit is from the ophthalmic artery, which is shown here. Notice that the ophthalmic artery courses through the optic canal, and it originates from the internal carotid artery. Let's suppose for a moment that we have an aneurysm of the ophthalmic artery here within the optic canal. What might a patient with this condition complain of? This patient is likely to complain of a loss of vision on the side of the aneurysm. This is because the aneurysm is compressing the optic nerve as it too courses within the optic canal. As such, vision in the ipsilateral eye can be lost. Once the ophthalmic artery exits the optic canal, it gives rise to a small branch called the central retinal artery, as shown here. This artery pierces the optic nerve and runs within it to emerge at the optic disc as it supplies the retina of the eye. That being said, the branches which are visualized through an ophthalmoscope are the branches of the central retinal artery. For the most part, the branches of the ophthalmic artery are named according to where they are going. The lacrimal artery, for example, is going to supply the lacrimal gland, along with the surrounding conjunctiva and the lateral eyelid. The long posterior ciliary arteries, as shown here, will supply the ciliary body and the iris of the eye. And the short posterior ciliary arteries are going to supply the choroid and the rods and cones of the eye. The ethmoidal arteries, shown here and here, supply the ethmoidal air cells and give branches to supply the frontal sinuses and the nasal cavity. Both the supratrochlear and the supraorbital arteries course in company with the supratrochlear and supraorbital nerves as they exit onto the forehead. The two main veins draining the orbit are the superior and inferior ophthalmic veins. The superior ophthalmic vein, shown here, begins at the confluence of the angular, supratrochlear, and supraorbital veins, and the superior ophthalmic vein will drain to the cavernous sinus. The superior ophthalmic vein is usually visible on CT, and it has a very characteristic boomerang-like appearance to it. The inferior ophthalmic vein, shown here, starts at the confluence of the angular and facial veins, indicated here. The inferior ophthalmic vein can drain either to the cavernous sinus, or it can also drain to the pterygoid venous plexus within the infratemporal fossa. And remember that these veins are valveless, meaning that they can transmit infections into the cranial cavity, where the cavernous sinus resides, for example. Now let's come back to the nerves, and this time let's take a look at the sensory nerves and those nerves which carry autonomic fibers. V1, the ophthalmic nerve, is divided into three branches, the NFL. Let's start with the F, which represents the frontal nerve. The frontal nerve is the largest of the three branches. This nerve courses anteriorly along the upper aspect of the orbit, and it divides into two nerves. It divides into a supratrochlear nerve, which heads medially, and a supraorbital nerve, which exits the supraorbital foramen, or notch. Both of these nerves, the supratrochlear and the supraorbital nerves, will be responsible for receiving sensory input from the conjunctiva and the skin of the upper eyelid, as well as from the forehead and the scalp. The nasociliary nerve, shown here, enters the orbit through the common tendinous ring. Along its course, it gives off the long ciliary nerves which innervate the eyeball, and they carry sensory information from the eye and from the corneal blink reflex. Nasociliary nerve also gives off posterior ethmoidal nerve, which is a sensory nerve that comes from the sphenoid sinus and the posterior ethmoidal air cells. Next, it gives off the anterior ethmoidal nerve. This nerve in particular carries sensory information from the anterior cranial fossa, the nasal cavity, and the skin of the lower half of the nose. Notice here in this image that the external branch of the anterior ethmoidal nerve emerges onto the tip of the nose. The infratrochlear nerve, shown both here and here, carries sensory information from the medial eyelids, the lacrimal sac, and the skin of the upper nose, over the bridge of the nose. Also in this image to the left, notice the supratrochlear nerve here. Recall that was a branch from the frontal nerve, not a branch from the nasociliary. During dissection, the lacrimal nerve will be found coursing along the superior edge of the lateral rectus muscle. This nerve innervates the lacrimal gland. More specifically, it carries sensory information from the lacrimal gland, from the lateral conjunctiva, and from the upper eyelid. From a relationship perspective, I'll also use this image to point out where the abducens nerve is running to innervate the lateral rectus muscle. We just said that the lateral rectus muscle contains the lacrimal nerve on its top border. However, the abducens nerve is seen here running along the medial aspect of the muscle to innervate the muscle itself. As a reminder, there are four parasympathetic ganglia in the head: the otic ganglion, the pterygopalatine ganglion, the submandibular ganglion, and the ciliary ganglion. During dissection, you'll attempt to find the ciliary ganglion situated between the lateral rectus muscle and the optic nerve. Here in the image at the bottom right of the screen, you'll notice this is the lateral rectus muscle with the lacrimal artery coursing along its upper surface. Here, indicated by the X, is the optic nerve, and encircled is the ciliary ganglion. The ciliary ganglion is associated with cranial nerve number 3, the oculomotor nerve. This ganglion is where pre- and postganglionic parasympathetic fibers synapse on their course to the eye. The parasympathetic fibers shown here in green are conveyed through the oculomotor nerve. Once these fibers enter into the ciliary ganglion, they synapse, and from there the postganglionic parasympathetic fibers are carried forward through the short ciliary nerves into the back of the eyeball. And these parasympathetic fibers will innervate the sphincter pupillae muscle and the ciliary body. More on that in just a moment. Now let's turn our attention to the sympathetic fibers. These sympathetic fibers, destined for the eye, synapse within the superior cervical ganglion, shown here. From here, the postganglionic sympathetic fibers are conveyed through the internal carotid nerve, and they jump onto the internal carotid nerve plexus. This plexus encircles the internal carotid artery. Within the orbit, there is a short sympathetic root which jumps from the ophthalmic artery to the ciliary ganglion. Those sympathetic fibers are conveyed through the ciliary ganglion, and notice that they do not synapse, they simply pass through that ganglion and through the short ciliary nerves to enter the back of the eye. Sympathetics can also be conveyed along the long ciliary nerves, which are branches of the nasociliary, in order to reach the eye as well. Once in the eye, the autonomic fibers innervate the iris. The iris is the colored portion of the eye, which is made up of two smooth muscles. The muscle fibers of the sphincter pupillae muscle are concentric, and they constrict the pupil of the eye upon stimulation by parasympathetic fibers. Here is the sphincter pupillae muscle. Once stimulated by parasympathetic innervation, this muscle constricts, closing the pupil of the eye. The pupil, by the way, is the black part of the eye, which is the opening. And in contrast, the dilator pupillae muscle, shown here, is innervated by sympathetics. The dilator pupillae causes the size of the pupil to increase. Recall that sympathetics represent the fight and flight response. So imagine yourself in a dark alley being chased by a perpetrator. Dilated pupils allow more light to enter the eye, which helps you to see better in a dim environment. In addition to innervating the sphincter pupillae muscle, parasympathetics also innervate the ciliary muscle for the lens. This is referred to as the ciliary body. The ciliary muscle is important in lens accommodation, which is necessary to focus on nearsighted objects. Note that the lens is suspended by zonular fibers, also known as suspensory ligaments. These ligaments span from the ciliary muscle to the lens itself, and when the ciliary muscle contracts circumferentially, the suspensory ligaments are loosened, which reduces the tension on the lens. This loss of tension causes the lens to bulge, and it thereby allows for accommodation for near vision. Let's briefly summarize. Parasympathetics destined for the eye will innervate the sphincter pupillae muscle, which causes constriction of the pupil, and it will also innervate the ciliary muscle, which causes accommodation for the lens. Sympathetics, on the other hand, destined for the eye, will innervate the dilator pupillae muscle, which causes the size of the pupil to increase. So what happens if sympathetic innervation to the eye is lost? This condition is referred to as Horner's syndrome, and it involves a disruption of the sympathetic fibers in the sympathetic chain. Without sympathetics, the sphincter pupillae muscle is unopposed. The patient, therefore, presents with a constricted pupil in the affected eye. This is called miosis. Secondly, as you'll see on the next slide, the superior tarsal muscle is under sympathetic control, and it is responsible for holding the eyelid open subconsciously. Disruption of sympathetics to this smooth muscle causes the eyelid to droop on the affected side, called partial ptosis. And thirdly, because sympathetics innervate sweat glands and the vessels of the face, disruption of sympathetics can cause a dryness of skin on the affected side, called anhidrosis. It can also cause a dilation of the cutaneous blood vessels, which results in a redness of the face and increased warmth on the affected side. Horner syndrome could be caused by trauma, by a Pancoast tumor in the apex of a lung, by a bone spur, by a cyst, or even by a demyelinating disease. The eyelids themselves are made up of fibrous tarsal plates that are suspended from the margins of the orbit by the palpebral ligaments. Here is the medial and lateral palpebral ligament. The palpebral portion of the orbicularis oculi muscle lies immediately superficial to the superior tarsus. And by definition, the palpebral fissure is the slit between the lower and upper eyelids. In viewing the eyelids from a sagittal section, the tendon of the levator palpebrae superioris, shown here, can be seen inserting into the superior tarsal plate. And as a reminder, the levator palpebrae superioris is innervated by cranial nerve number 3, the oculomotor nerve, and it functions to open the eyelids. That is, it functions to open the upper eyelids specifically. The superior tarsal muscle, shown here, also assists in helping to hold the eyelids open subconsciously. And as we just pointed out on the previous slide, this muscle is a smooth muscle and is innervated by sympathetic fibers. The tarsus also has tarsal glands associated with it. The oily substance secreted by these glands mixes with the tears from the lacrimal gland to increase the viscosity of tears so that the tears don't evaporate as quickly from the surface of the eye. And lastly, the conjunctiva, shown here, is a layer of moist epithelial tissue that serves as the inner lining of the eyelids, and it reflects onto the sclera of the eye, which is the white part of the eye, shown here by the X. There are many small blood vessels that course through the conjunctiva, which explains why the eye becomes red in response to either injury or infection, such as pink eye. The sclera is also vascularized, while the cornea, this anterior clear projection shown here, is not vascularized. If you wear contacts, at one time or another the contact has probably slipped off of the cornea and gotten lost in your eye socket. Some individuals think you can lose your contact behind your eye, but this is simply not true. The contact typically becomes trapped in the superior conjunctival fornix, shown here. This cavity is created by the reflection of the conjunctiva from the eyelid onto the sclera of the eye. If the conjunctiva doesn't stop the contact, the periorbital fat sure will. Do note all of the periorbital fat you'll have to get through in order to complete your orbital dissection. Tears play a very important role in helping to protect the eye from both injury and irritation. Even the smallest of dust particles can irritate the eye. Tears or lacrimal fluid is secreted from the small lacrimal ducts which extend from the lacrimal gland into the lateral superior conjunctival fornix. Tears are then spread across the surface of the cornea during blinking in order to keep the cornea moist. In the medial corner of the eye, which is known as the medial palpebral commissure, the tears accumulate in an area known as the lacrimal lake. It is in this area where small channels, known as lacrimal canaliculi, open onto the eyelids as the lacrimal puncta. If you hold down your bottom eyelid and look at it in the mirror, you'll see a very tiny opening, which is the lacrimal punctum. Through capillary action, these lacrimal canaliculi convey the tears to the lacrimal sac, which is the superior dilation of the nasolacrimal duct. From here, tears are conveyed through the nasolacrimal duct into the nasal cavity and are emptied into the cavity at the inferior nasal meatus. The inferior nasal meatus is a concavity which is formed in part by the inferior nasal concha, which is a bony projection off of the lateral wall of the nasal cavity. So why do you get a runny nose when you cry? Because tears are conveyed from the eye through the nasolacrimal duct and into the nasal cavity. So your runny nose mostly occurs from an accumulation of excess tears. Now let's examine the pathway by which parasympathetic fibers innervate the lacrimal gland to stimulate tear secretions. These parasympathetic fibers are first conveyed through the facial nerve, cranial nerve number 7. As they are conveyed through the facial nerve, they also course through the geniculate ganglion. As you may recall from the facial nerve video, coming from the geniculate ganglion is a nerve referred to as the greater petrosal nerve. These parasympathetic fibers course through the greater petrosal nerve, and once the greater petrosal nerve meets up with the deep petrosal nerve, which is carrying the sympathetic fibers, that nerve changes names and becomes the nerve of the Vidian's canal, or Vidian's nerve. It's also referred to as the nerve of the pterygoid canal. This area here represents the pterygoid canal. The parasympathetic fibers destined for the lacrimal gland continue their course anteriorly through Vidian's nerve until they reach the pterygopalatine ganglion, as shown here. Within the pterygopalatine ganglion is where the preganglionic parasympathetic fibers synapse with the postganglionic parasympathetic fibers. Notice that the postganglionic fibers did not synapse in the geniculate ganglion, they simply passed right through it. Once the synapse occurs, the postganglionic parasympathetic fibers jump onto a communicating branch of the zygomatic nerve, which is associated with the maxillary nerve, and from there they make their way up to the lacrimal gland. Once these fibers reach the lacrimal gland, they stimulate tear secretions. Here is a slightly different perspective of the same pathway. The parasympathetic fibers destined for the lacrimal gland begin in the facial nerve. They course through the facial nerve and through the geniculate ganglion, and from there they exit the geniculate ganglion at the greater petrosal nerve. Their fibers are conveyed through this nerve until the greater petrosal nerve unites with the deep petrosal nerve to form the nerve of the pterygoid canal, shown in this area here. The greater petrosal nerve is purely a parasympathetic nerve, while the nerve of the pterygoid canal is considered a mixed nerve because it contains both parasympathetic and sympathetic fibers. The nerve of the pterygoid canal terminates at the pterygopalatine ganglion, shown here. Within the pterygopalatine ganglion, the synapse occurs between the preganglionic and postganglionic parasympathetic fibers. The postganglionic parasympathetic fibers are then conveyed toward the lacrimal gland through a communicating branch associated with the maxillary nerve. This communicating branch can connect to the lacrimal gland directly, or on occasion it will feed into the distal end of the lacrimal nerve, which is shown here. Recall from a previous slide that this lacrimal nerve is purely sensory, and it is a branch of V1, the ophthalmic nerve. As iterated previously, knowing the routes by which autonomic nerves reach their target tissues can be very important for localizing nerve lesions. So do take the time to carefully review all of these pathways. This concludes this video on the orbit and its contents. Until next time, take care.